It was about personalized medicine in multiple sclerosis. It means to tailor and customize the treatment to the individual, particularly for a disease like multiple sclerosis, where the disease is clinically heterogeneous. It can take different clinical courses, and the treatment response is not universal. Some patients respond to certain drugs, others don't. So the goal of my talk is to review the evidence that support customized medicine in MS and what steps needs to be taken to achieve that goal. The first thing to understand is that MS may be pathologically different among different patients, and that the immune mechanisms that lead to the disease process are heterogeneous. Understanding those specific pathological mechanisms in individual patients can help target the process with the appropriate drugs. The second important thing, as I mentioned, is that although we have several drugs for multiple sclerosis, clinically we see that different patients respond to different drugs. And the challenge is to find metrics that would tell us who is likely to respond to what. One area of interest in my laboratory is to discover biomarkers that help us predict who is going to respond to what. And I specifically went over our research identifying biomarkers that help us predict the response to two of the main drugs used in MS, interferons, as well as glutaminyl acetate. Personalized medicine is to try to, as I mentioned earlier, to identify drugs that are appropriate for a particular patient, enhancing the response with minimal side effects. There are, more than 10, 12 medications right now, and because of that, personalized medicine becomes important. The more medications you have on the market, particularly expensive medications, as in the case of MS, the more there is a need to target treatment and achieve personalized therapy. Depends on stage of the disease, the treatments under considerations. Right now we use some clinical cues to tailor therapy. Some drugs are appropriate for early MS. Other drugs are more appropriate for advanced disease and aggressive disease. And that judgment is mostly made based on the clinical picture and the MRI. But we can refine that, and refinement is going to come through understanding the immunology and how these drugs work, and what are the pathological processes in the individual patients, so you can be more precise in targeting therapy. At this point in time, it's for relapsing remitting MS, because most of the drugs we have are for relapsing remitting MS. But I could see the same being applied in the future as newer medications are found to be effective in progressive disease.